That controversy was not there. The three-stage procedure has been done earlier, but subsequently I started feeling a lot about this three-stage procedure because of the lots of problem crept up after 5 years or 10 years. So I started deciding whether I can you give the volume? Okay. So I want to share my experience and controversies of single stage versus multi-stage procedure. So while dealing with a neonatal ARM, two questions come in your mind. Number one, whether there is any life-threatening associated malformation which requires immediate attention before you venture for surgery for neonatal malformation. Now, next question is, if there is any need for colostomy. If not, then why not manage by single stage? So that is my experience of in three stage. First, earlier part from 80 to 88, I used to have, most of the people used to have do it by abdominoperineal pull through or sacroperineal or combined abdominal-sacroperineal pull through based on Stephen's concept of pivotal swing. So after the 88, after attending the first PSRP workshop of Mr. Alberto Pina, I started doing the three-stage procedure of PSRP, covered by colostomy and then colostomy closure. But from 95 onwards, I started doing single-stage procedures in newborns without any protective colostomy. Why I have switched on? Question may be asked, why I have switched on for single stage instead of staging procedure? Why I should bother for those headache for running in the middle hours of night, doing the surgery or stabilize the patient so that we can manage it in the morning hours. So this is because I have seen that high morbidity, poor compliances. After having 10 years follow-up, more than 38-40% lost in the follow-up. So by that, I started thinking that with colostomy, some of the patients came at adolescent age group for doing the second surgery. So that thing stimulated me to do it single stage. Another important thing in poor patients, cost of 3 admission, 3 operation is much more. Whereas if it can be done in neonatal period, at least that cost has been 1/3. Psychological impacts not only to the parent but also the patient is there, and poor cosmesis because of the 3 scar in the abdomen, 2 scar in the abdomen and 1 in the perineum. So then I compare this stage procedure with that of single stage procedure in my own cases. This is a historical control because stages procedure had been done earlier from 80 to 94, and the subsequent primary operation is being done single stage operation 95 to 2012. So here you can see that first number of cases of 673, but follow-up after 3 to 14 years, it becomes 200. So those patients are lost in follow-up. So I started writing letter to them, and some of them then turn up with the colostomy, and the colon is disused, narrow, not developed properly. So then I decided that I will go for primary single-stage procedure. But primary single-stage procedure should combine either PSRP only or PSRP at abdominal pull-through. And some cases I have tried to establish which is better by abdominoperineal pull-through. Now, after assessing the continence of the two groups, I have seen that you can see in the first side is staged procedure where 42% or 44% good continence is there, whereas it is around about 70% in cases of primary single-stage procedure. Next important question comes, it is again another controversy in that era, that whether distal part of the fistula region totally preserved or not. So initially, a proponent of those said that it is ectopic enough, it should be preserved, so that continence result will be better. So, but I started thinking that this anywhere there is a abnormal thing, it has to be excised and pulled by normal things. That is my philosophy. So I started studying this distal part by excising the distal part and adjacent tissue from proximal part to see the structural changes in these two parts. So histologically, the distal part is having lots of thinning out of the wall, as well as inflammatory eosinophilic cellular infiltration, along with disorganized muscle in the distal part. So if you pull it, it will not have the proper sensation, proper function, proper contraction. So better, whereas the proximal part on the right hand side, you can see the more or less organized circular layer. So I prefer to excise the distal part, but still I want to make it scientifically proved. So I have studied the motility of those proximal and distal portion of the adjacent fistula region, and it has been observed that histamine-induced contraction in the proximal segment is adequate enough, whereas that of distal segment is not negligible. Same thing happens with inhibition of the contraction by acetylcholine, which is much more easily inhibited by distal segment, whereas it is not at all mobilized by the proximal segment. Here it is distal segment where the relaxation is not there. So, in other words, the distal part of the fistula region or adjacent to that, if you pull it out, it is functionally abnormal, structurally abnormal. So with this study, I can say that I have at least been able to convince people that based on scientific proof that distal part should be excised and pulled it by the normal body. Now, next stage question is why single stage procedure should be performed at newborn? Why not delayed? Delayed means you have to do a colostomy and then do it. But disadvantage of delaying is you are delaying the development of the part. So the first sensation of cortical stimulation for rectal distension develops in the first year of life. And if it is not stimulated by distension of the rectum, by mobility of the rectum, by peristalsis of the sigmoid colon rectum, the sensation will not be adequate enough to establish good continence or good function, bowel function. Another further disadvantages are dissection of the is easier in the newborn. All of you have experienced that any tissue dissection in newborn is much more easier than that of subsequent period. No need of tapering here. It can be immediately placed inside the funnel, and it eliminates the urinary tract contamination at birth and maintain the urinary tract continuity at birth. So this I have during doing the surgery, I have started modifying the techniques. So initially I used to do the classical Pinner's operation by opening the pouch and then doing the dissection, but it is loaded with meconium. It stains the area and it is very difficult to dissect, and every time you have to wash it out, clean it out, and only. So then I thought that in a esophageal pouch, if you proximal pouch, you dissect higher up, then it go down, it is become easier because there is no attachment between the two. Here also, if you go higher up, the pouch becomes free. So from there you start dissecting down, and then you can approach the fistula and you can close it in between ligatures. So that way you are avoiding contamination by meconium and blurring of your field of vision. So this is the procedure, immobilized and then normally placed. Another modification I have done for female vanorectal malformation newborn, because in newborn, if you cut the fourchette, open the vestibule, then subsequently I have seen that while healing process goes on, the fistular region and the vagina opening becomes, vestibular region and the vagina opening becomes small. Whereas if you dissect while doing an incision, just stop before the posterior fossette and then dissect the rectal pouch from the vagina and flushly ligate it close to the vestibule or vagina. Here in the left hand side, you can see intermittent ligature is being put and it is being divided. Then you pull the bowel, it becomes more cosmetic results and good looking perineum, good looking vestibule. Even at times when they grow up, you cannot imagine that normal vestibule appearance is there, which is at times missing in if you open the posterior fossette. Now pouch colon, I have studied pouch colon. There are lots of papers and other things are there, but my saying is pouch colon is abnormal. That's why it has to be excised. But it can be used for some other purpose, well and good. But as such, it has no normal proper structure in it. But if it is total pouch colon, then what Dr. Raychaudhuri was showing, that there is a lot of diarrhea in the initial part if you do an anal pull through, ileal pull through. But if you want to construct a tube, it should not be more than 3 to 5 centimeters in newborn, because the coloplastic tube grows with the growth of the child. So earlier I used to make 10 centimeter and it grows up to 28 centimeter in adolescent. So then lots of pouchitis, tesis and intermittent enterocolitis just takes place. So in order to avoid that, if you at all want to make a spout, tuboplasty with the pouch, it should not be more than 3 to 5 centimeter. then pull it down. Now, this has also been published as single stage procedure for all variants of pouch colon. There is no need of doing any colostomy or diversion, which can be managed by either primary abdominoperineal pull through or abdominal PSRP, whichever you prefer. Abdominal PSRP needs to change of position, whereas abdominoperineal pull through doesn't require that. Again, I assess the continence in these two groups. Again, you can see the 43% is good continence is single stage, whereas 26% in good continence of stage procedure. Histopathology of again, this is disorganized muscle and focal area of erosion, hypertrophy of the muscularis mucosa, chronic inflammatory cellular infiltration, hemorrhage in the submucosal level, and constriction band, which I have found in uniquely in this pouch colon in the circular layer, multiple constriction band. That may be the reason for stasis of the fecal contents in the pouch colon if you pull it down by making a tubuloplasty. I have studied the functional outcome also by, again, same way of contraction, and it has been seen that pouch colon is having no spontaneous contraction and hardly it moves with the stimulation of the histamine, that is chemically evoked potential is very less, negligible. So all this suggests that pouch colon should be excised as much as possible. But if you want to at least reconstruct the tube, that should be smaller enough so that it grows in length with the growth of the child and growth of the intestines. Now, there are some contraindications. You cannot say all the patients I will operate for single stage. There are some contraindications like any other procedure. If there is severe life-threatening congenital malformation, then better to do stage procedure. Similarly, sepsis, severe sepsis, or NEC with perforation. Bowel perforation has already taken place. So already peritonitis is there. There is no point of doing. You have to survive the baby and then do the procedure, whatever you want. Another is extreme prematurity. If their motility is so low, if you do a pull through, then there will be stasis. Again, there are a lot of problems. And common cloaca, as Dr. Raychaudhuri has pointed out, there is always performed by diversion colostomy followed by the procedure. Now, in these cases, follow-up is very important. So follow-up, we are familiar with the different scoring system, which is clinical follow-up. But I used to do Kelly scoring for follow-up, and that I am familiar, so I followed it for the continence assessment. But I have seen that with this follow-up, it is a personal observation. You have to document it. So I started doing MRI in these cases. And that is called combined MRI and clinical follow-up by scoring. What are the parameters observed in MRI? Levator muscle, its development on both sides. Then anorectal angle, which is whether it is obtuse, acute, or straight. Now, rectal diameter, rectal wall thickness. These are very two important problems because the diameter is more than 4 centimeter and thickness is too much more than 1 centimeter. Then you are managing a difficult case where you have to do drainage procedure and you have to do further redo surgery. Centrally located rectum, it is very important. Sometimes in a newborn, particularly in an institution where some of the residents are operating, you are observing. And during that time, you may have a phone call in the emergency meeting or something that you may not be continuously monitoring it. So that time you may see that some of the cases are rectum is pulled out eccentrically. So those patients are the ideal for redo surgery. External sphincter development, which is very important for continence. If the external sphincter is well developed, then continence will be much more better. And tethered cord, there are lots of controversy whether all tethered cord needs surgery or not. So it is tethered cord blanket statement cannot be needs to be tethered until unless there is neurological deficit. Now I combined my ARM case follow-up cases with clinical scoring in the bottom of it and that of muscle development by MRI. So you can see here also in stage procedure and single stage procedure, just like clinical scoring, here the muscle development, levator hammock, then external sphincter and puretal sling, all are far better developed. So 2 plus means good, 1 plus means fair, and minus is poor. So all are better developed if you do a single stage procedure, which gives the stimulus for development of this muscle because they are just like a Jamie, you are working to develop your muscle. Here, if you pull the bowel, again, they are exercising, so they develop much more better. And if you do a diversion colostomy, they remain disused, so their growth potential become less. So this is another logic which I want to expressed in front of you. Now, I started assessing three variants of primary single stage procedure. One is PSRP through or abdominal PSRP, another is abdominoperineal pull through. So again, by clinical scoring and MRI, with both combined data, I have concluded that PSRP or abdominal PSRP over abdominoperineal pull through is better in terms of muscle development, in terms of continence, in rectovulvar prosthetic or rectourethral fistula. Whereas that of rectovaginal fistula, all three approaches are having more or identical continent or muscle development. Now, there are some future scope of further evaluation because parents often ask about impact of the surgery in the long life of the child about continence of stool. So, the present counseling done by any eminent pediatric surgeon is imprecise and based on his personal experience and professional opinion. So, that cannot be foolproof in the court of law as well as foolproof, that cannot be justice to the parents also. So anatomical features should be identified by either antenatal neonatal preoperative MRI, preferably CT or MRI, whichever you want, so that you can have anatomical features identification before surgery in the newborn period, including type of MRM, degree of sacral development, and the features of spinal cord, whether the spinal cord is fully developed or there is some abnormality in the spinal cord. Thereby, all these features subsequently implicate the continence results of these children. So, but all these anomalies frequently occur simultaneously. So, relative predictive value of each is cannot be assessed right now. So, there should be some more study in the form of a EMG study, in the form of a rectal pressure manometry in the postoperative period. Thereby, you can incorporate more. I have told that contraction of the bowel may be stimulated by drugs. The drugs can be selected, drugs can be given for achieving better continence. So that is the future study. I left it for the newer generation. Furthermore, most previous studies or most counseling scoring systems are for continence are not used as a standardized manner. That's why I have told I do Kelly scoring, somebody does taken back scoring, somebody does whatever he wants, PSR, PINA scoring, whatever it is. But there should be now rational, individual, generalized scoring, including incorporating the MRI findings along with the clinical findings. If it is incorporated in a large scale, data will be collected, then you will feel again further support of why primary PSRP should be done, because it develops the muscle much more faster, much more better than comparison of staged procedure. So controversy of single stage versus stage procedure, I think with my presentation, with my documentation, I am able to now that with the new development of imaging, neonatal care facilities, single stage APR is feasible, safe modalities of treatment in these anomalies. So still, I want to conclude my talk with a famous saying of Sir Albert Einstein, that learn from yesterday, live for today, hope for future. So future is with the younger generation, and never stop questioning by yourself. If you are not asking question on yourself, you won't be able to generate your thought process for future modification of your techniques or whatever you want to justify your techniques. Thank you very much for patience hearing.